Good morning. I'm Brian Edwards, the Vice President for External Communications for the American College of Surgeons. Welcome to our live stream news conference on treating obesity and what everyone really needs to know about understanding treating obesity with weight loss medications and with weight loss surgery. The American College of Surgeons is the largest professional association of surgeons in the world, and we are here in Chicago this week at the American College of Surgeons Clinical Congress, where thousands of surgeons are gathered today and this week to learn and grow as professionals and to better understand how they can advance treatment of patients across the world back in their communities. The ACS sets the highest standards of surgical quality around the world. We bring together the biggest experts so that we can understand how to advance patient care, and we design those standards and advance patient care in that way. In this case, the weight loss surgery and bariatrics and weight loss medications is growing in immense popularity. People really want to understand what's going on. It's really, in terms of information, there's a lot of information out there, but we want to make sure that people have the information they need to know so that they can make the best decisions for themselves. So we've brought together an unbelievable panel of experts today to help answer questions that are on patients' minds and really provide the information that they need to know to make the best decision for their care. We invite members of the media to post questions in the chat. They can also send questions via email to pressinquiry@facs.org, and we will get to as many of those questions as we can. At this time, I'm delighted to introduce our moderator, Dr. Matthew Hutter. Dr. Hutter is the chair of the Department of Surgery at the John Seeley School of Medicine at the University of Texas Medical Branch in Galveston, Texas. He is a nationally and internationally recognized leader in the quality movement, especially in the field of metabolic and bariatric surgery. So Dr. Hutter will introduce our panel and then engage in some great discussion and ongoing information, and then we'll take your questions, and then we'll proceed from there. Dr. Hutter, thank you.
Well, thank you very much for having us here today, and thank you all for listening here. Obesity is the greatest disease of our public health crisis right now, and we've all dedicated our lives towards treating this disease. And the best treatment for obesity is surgery. And right now there are these new medications, the GLP-1s, maybe not new, but now people are learning more about them, and it's a great tool in the toolbox, something that can help conquer this disease, hopefully, or at least put it into remission, which is our goal. We would love for this not to be a problem. We would love for there to be a prevention, a cure, or something else other than surgery. Right now, surgery is the most effective and life-saving treatment that there is for the disease. These medications are promising. We look to explore that intersection between the medication and surgery, but really at our heart, it's how to treat this patient population the best. And that's why we're doctors, that's why we're surgeons, and that's why we're here today. And I'm glad that we were having this conversation because a lot of people didn't realize how much of a disease this was and how it was impacting our populations. Our job, I think, is one of the best jobs in the world. We get to sit there and hear how it's impacted and changed their lives. And now we're hearing the same thing from people who are on these medications. And it just makes joy to my heart to hear these people whose lives are transformed by this weight loss journey. But it's not just the weight loss, it's their health. So we have esteemed colleagues today. We'll get right into the questions. Each panelist will talk for a few moments, and then we're really excited about answering any questions that are out there. So getting right to it, our first panelist is Dr. Thomas Tsai. Dr. Tsai is a minimally invasive gastrointestinal and bariatric surgeon, associate professor at Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. He's also an associate professor at the Department of Public Health for the T.F. Chan School of Public Health at Harvard as well. He's currently the medical director for health policy research at the American College of Surgeons and an active bariatric surgeon. Dr. Tsai.
Thank you, Dr. Hutter, for the introduction. It really is great to be here today. As Dr. Hutter mentioned, we are in a current public health crisis where obesity is not just a current crisis in public health, but a growing crisis, an epidemic in public health. Over 40% of Americans right now have obesity. And what that means in absolute numbers, over 100 million individuals in the U.S. are suffering the healthcare consequences of obesity. And what the research is telling us is as we look forward to 2030, that epidemic will continue to grow, with as many as almost half of the U.S. population with obesity and almost a quarter, 25% of the U.S. population suffering from severe obesity. So not just obesity, but also the consequences of heart disease, diabetes, high blood pressure, high cholesterol. But despite this public health challenge, this is also an immense opportunity for public health and for clinical medicine and surgery. In many ways, this is the golden era for the treatment of chronic disease. We have highly effective medications, endoscopic, and most importantly, the gold standard surgical treatments. And what I tell my patients is that we're in the era of precision surgery. People think about precision medicine, but we actually have precision surgery where we can tailor the most effective surgical treatments, whether it's sleeve gastrectomy, gastric bypass, or other surgeries to not just improve and reduce the weight from obesity, but actually have people live healthier and more functional, higher quality of lives, and treat their heartburn as well, and treat all of their other conditions. And when I explain this to my patients, even though I'm a public health professor, for an individual, it's not about probability or a population average, it's about what their life is like. And I found what's most powerful as a parent myself of young children is that the data are very, very clear that weight loss surgery, bariatric surgery, can actually increase your quality of life, increase your life expectancy as much as 6 years, or you can live as much as 9 years longer if you're suffering from diabetes. So in many ways, we're living in this both the best of times, but also the worst of times. And the challenge for all of us in the surgical profession is to make sure that all of our patients have access to the gold standard medical, but most importantly, the highly effective surgical treatments so they can live their best and high quality lives.
Live longer and live better. That's definitely the theme there. So Tom, thank you very much, and look forward to further comments as we go further. Our next panelist is Dr. Richard Peterson. Dr. Peterson is a bariatric surgeon. He currently serves as the president of the American Society for Metabolic and Bariatric Surgery. That means he was elected by all the bariatric surgeons in the country who are part of this to be their president. He is also a professor and chief bariatric metabolic and surgery director at the University of Texas Health Science Center at San Antonio. Dr. Peterson.
Thank you, Dr. Hutter. Appreciate it. So the other conversation we want to have is the difficulties with regards to policies and insurance hurdles that are out there for individuals. I had a wonderful colleague talk to me about access and utilization. And the reality is if you have a Peloton in your room, you've got access to it. But utilizing it is a different story. And not everyone has the opportunity to utilize what they have in front of them. There are some challenges with insurers. Most insurers, surprisingly, do cover metabolic and bariatric surgery. So oftentimes people are worried that they don't have coverage, they don't think they have coverage. But the truth is, many people do. So be aware of that. And again, they just don't realize that they have the access to that. So they don't realize they have a Peloton in their room. The other part of it is that, a lot of insurers do follow the Centers for Medicare and their guidelines. And currently, as it stands, that's a covered benefit with Medicare. There are some nuances to it, and we can get into that in a little detail as we have our conversation, because I don't want to confuse the group too much, but the reality is it is a covered benefit. The interesting part, though, is that medications, in many cases, are not. And that just becomes a cost-effectiveness issue, and I can talk specifically about our system in Texas, which Dr. Hutter and I are now, we are in the same larger system together. So I'm glad to have you as a colleague in that area now too. Thank you. So we'll have some more discussions about that a little bit with respect to how the insurance comes into play. But I think the most important piece of that understanding is that more people have insurance coverage for this disease than they think. With respect to policy, we're working very hard at the level of the ASMBS and working with our colleagues at the American College of Surgeons as well with the Centers for Medicare and trying to improve policy on a national level. So thank you.
Thank you very much, Dr. Peterson. Yes, so access to care has always been a critical issue, and that's been a real focus from the surgeons, and we've done a great job. I think, pat ourselves on the back, but all the people who listen, who understand, and all the policymakers who listen and understand that it is a life-changing opportunity that we're providing for those patients. And we've moved the needle on that. And it's not always the case for the GLP-1s right now. So that needs to be better. And the costs need to come down. We need to find value in this equation. But right now, surgery is like a GLP-1 pump. It kind of just gives this GLP-1, and once we implant that pump, it's a gift that keeps on giving, and it continues to make a profound impact. So yes, advocacy is important. Access is critical for those medications, but as well as surgery. But yes, surgery is available, and people don't really realize that. So that is a good option. In our third, saving the best for last, Dr. Mona Misra. Dr. Mona Misra is a bariatric and advanced laparoscopic surgeon and associate director of the Cedars-Sinai Marina Weight Management Center and director of the bariatric program at Beverly Hills Physicians. Dr. Misra was also elected to the board of directors by the members of the ASMBS as well, and has served proudly in that position. So Dr. Misra.
Thank you so much for the introduction, and thank you all for being here. I just think it's really important to emphasize again that obesity is a chronic, complex disease affecting millions of people and increasing their risk of serious health problems like diabetes, high blood pressure, heart issues, high cholesterol, sleep apnea, and many other diseases. And I think our ultimate goal as healthcare providers is to provide to help patients lose weight safely, to improve their health, to improve their quality of life, and to improve and extend their years of healthy living. And I think we're all really encouraged of the increased awareness that GLP-1 medications have brought to the conversation about obesity, because these medications like semaglutide and tirzepatide have really helped millions of people understand that obesity is not a failure of willpower, it is a treatable medical condition. And actually about 18% of Americans have actually tried GLP-1 medications, either through their healthcare providers or online services, and it really shows a clear demand for safe and effective solutions for weight loss. It is essential, though, for patients to have accurate information when they're making their decisions about their care. So GLP-1s can help patients lose about 10 to 15% of their total weight, on average in real-world settings. So in clinical trials, it is a little bit higher. They're highly supervised, and it's about 15 to 20%. But what is important to understand about obesity is that, like high blood pressure and diabetes, it is a lifelong disease. And so the medications are designed for long-term use because obesity is a lifelong condition. So just like you wouldn't stop your blood pressure medication when your blood pressure is under control, generally you're not to be stopping those GLP-1 medications once it is working. So when patients stop these medications, unfortunately, typically the weight comes back. So studies are showing that about 2/3 of patients usually stop these medications at about a year, over 80% stop at 2 years, and unfortunately that weight is regained. So for many, GLP-1s is an effective tool. It's a good tool. But for some, it is just not enough for them to reach their goals. So for example, we'll take someone who weighs 300 pounds. 15% total body weight loss is about 45 pounds. And although that is a great start, typically that's not enough for them to reverse these serious diseases like diabetes and high blood pressure. And that's where metabolic bariatric surgery is a really great option, because typically what we're seeing with the surgery is about 30% total body weight loss, which is about 90 to 100 pounds on that same patient. And so it's safe, it's effective, it's long-lasting, and there are studies that actually show that it's almost safer than gallbladder surgery. It is one and done. Most patients are going home after a week. And most importantly, it can put diseases like diabetes, high blood pressure, high cholesterol, sleep apnea into remission. And I think that's really important. It can improve heart health. It can improve fertility. There are actually studies showing that it's easier for patients to get pregnant, and the actual pregnancy itself is safer as well. There's also studies that show it decreases the risk of cancer. There are 13 cancers linked to obesity, and we're able to help decrease that risk. So we're improving quality of life. We're adding years to people's lives, up to 9 years to people's lives. And looking at some of the latest research on cost effectiveness, we are seeing that actually surgery is significantly more cost effective than the medications alone. So I think the most successful approach is looking at combination. We need to have nutrition and exercise therapy and physical activity, behavioral support, medications, and surgery potentially together. So whether the patients need medications, whether they need surgery as their best option, or both together, I think it's important for them to have a individualized plan, because our goal is to help patients be informed, supported, and successful for long-term success with their weight loss. Thanks.
Wow. And that's why we love this job, because we've been providing this care to these patients. We see them go through this journey. We see the impact, and each one comes back with a different story. We're now focusing on quality of life and patient-reported outcomes because it's such a powerful story of this journey that they're going through. The passion that Dr. Misra just showed here is felt for me every time I see one of these patients in follow-up, and is why we love those jobs, and why we're hoping that these medications can bring the same joy or same impact on their life. Right now, they don't. You saw the difference in the impact for some of the patients who are at higher levels of obesity, but they're a great tool and an adjunct, and we're going to explore that very more. So thank you for that. One comment was they're gone within a week. They're gone within a day or two after surgery. So now it's done laparoscopic or robotic. It's minimally invasive. Almost all the procedures are not a big cut. They're just as small as a gallbladder being removed, and the patients go home either the same day or the next day with this life-changing treatment. So yes, maybe out of work for a week, but
Back to work in a week.
but out of the hospital either the same day or the next day. And most of the people don't even have pain medication when they go home. That's what we're talking about here. So this myth of what surgery was is not what's happening today. These concerns about how dangerous it was, it's not happening today. Yes, any surgical procedure can have complications or occurrences, but here at the American College of Surgeons and with the ASMBS, we've created data collection programs to assure that it's safe and effective. So we track every patient who is done at one of these accredited centers to make sure that they're providing the highest quality of care. And it's not at one or two hospitals, it's 1,000 hospitals that provide this life-changing care. So yeah, we're very serious about making sure it's safe and effective, and now we can really appreciate the impact that it's had on people's lives. Alrighty, well, now that's all our presentation. No slides, as you can see. So this is the fun part where we get to answer the questions. And well, why don't I start with a few questions here for the panelists as we get going. I do encourage anybody who's in the audience or online to send in any questions, and we look forward to answering those as well. But to heat things up and get things going, I'll throw one at Dr. Sai first. Dr. Sai, some patients with obesity have been told their condition is a personal failing. How can we shift the conversation towards obesity as a disease and not just a weakness, not just a cosmetic thing, and not just a personal failing for that individual patient?
Yeah, thank you, Dr. Hutter. I think that's one of the most important issues for us to address and communicate and honor and respect what our patients are going through. And as Dr. Misra so passionately explained, obesity is a disease, and I can't, count all the number of times patients come into our offices and just feel heard and seen, and recognizing that their health is, we can actually treat and improve their health. So I think that is fundamentally, recognizing and hearing and seeing our patients is one of the most important things that we can do, and we do as surgeons. And this often kind of breaks down as, is the solution to this epidemic that we've described? Does it surgery? Is it medications? Is it just exercise? Is it just diet? And it's not these individual choices. It's about doing all of the above to make our patients and our society healthier. I think about my trauma surgery colleagues. They deal with patients who are severely injured, and we don't argue, do we wear seatbelts, do we have traffic rules, or do we have trauma programs to take care of patients once they're injured? We both need the prevention, and we need the treatment of patients when they're very, very sick. And that is, I think, the conversation that we should be focusing on, is both the foundation of eating healthily and having diet and exercise, but that is not enough, because we've shown after decades of research that this is a metabolic disease, and it's unfair and to put all of this on the patients alone, that this is a condition that can be treated, is effectively treated, and actually can, if it effectively treated, help people live longer and healthier lives. So I think that's the conversation we need to be having with patients is, how do we actually meet the patient's goals, and how do we actually leverage all of the decades of innovation and investment in the best medications, the best what we know about comprehensive management of metabolic disease, and cutting-edge surgery. As Dr. Hutter mentioned, one of the most important things for patients to realize about surgery is that it's continually innovating and evolving. And when I said that there's truly era of precision surgery, we can actually guide this to meet the patient's expectations, needs, and healthcare goals. So this is really a treatable disease that needs to be treated, and it needs to be treated to make not just individual patients healthier, but also make our society healthier as well.
Dr. Sai, great points here. It is amazing when people walk into our office. A lot of them don't come into the office. To be honest, that's the biggest challenge, is that there's so many people who have this disease who we can treat who don't come into our office because they've been told their whole lives they just need to run more, eat less. If that worked, it wouldn't be a problem. It wouldn't be a disease. And so that alone for this disease is not enough. So for some, few, maybe that does, but you can't mean that that works for everyone in their lives. So hearing them coming in and telling those stories are important. And then hearing those stories later on, once this is lifted from them, and hearing what the changes in their lives are later on, these patients didn't even realize some of the impacts that it had. And all of a sudden, they're out from underneath this cloud, and they can see the sunlight, and it's a wonderful transformation. Dr. Peterson.
I would say, Dr. Sai, I think what you said really resonates. One of the points you mentioned too was that when patients come in, they have this relief because of the conversations that we're having with them. I think that oftentimes the bariatric surgeon who's seeing them is the first person to be telling them that they have a disease and it's not their fault. And so going towards that, we really need to educate going forward about this, because it's this stigma. Dr. Ann Rogers' theme of her last year in the ASMBS was beating the stigma of obesity. And so part of that is just letting patients know that it's a disease, which I do believe that with the medications as they came forward, really raised this as an awareness that this is a disease. So people, I think, are starting to see that now. But the reality for us is being that compassionate provider who helps someone understand that it's not their fault. That this is a disease that's treatable, as you eloquently said, with all of the things that we can do. I like the precision treatment is what we're talking about. So,
excellent. Dr. Peterson, what does insurance coverage look like for weight loss medications and surgery, and how does that differ across states?
Right. So that's a big question, and I appreciate you asking me that. The reality is that insurance coverage clearly by insurer and by state is very different. In the political environment of our country, certain states had not adopted, the national health care options and things like that. And so not every state behaves the same. And then definitely not every insurer behaves the same. There are systems, for example, and I'm part of one of those systems, that the cost of the medications, as they analyzed that, became it was too expensive for the system to continue coverage of the medications. In fact, at the time in 2023, in our system, we actually had to stop covering those medications because it was going to cost the system over $25 million to do that. So the cost of the medications, unfortunately, in the U.S. are higher, and so insurers are moving away from that. We've been working hard now I think we're on our 14th year with the Treat and Reduce Obesity Act, trying to have medications covered. Medications are not covered under Medicare for obesity. There are other, disease states like diabetes or heart disease or sleep apnea where the medications may be covered. But again, that's still very expensive. Whereas now, for the first time ever, as I was talking to some of my colleagues in private practice in my area, are getting referrals from the insurer for surgery. They're sending their members to the surgeons to have that because the cost effectiveness of surgery today is so much better. So just having that understanding, and I think one of the things when it comes to the coverage, and someone does get medications, and we were in Washington D.C. on the Hill, and I had a patient who was one of the group, and she had been on medications, doing quite well, frankly, and there was no more coverage for her. And the desperation for that individual who all of a sudden had this life-changing treatment, it was being taken away. Turns out, with surgery, that's not an option. Surgery, you get the surgery, you get to keep the surgery, actually, for the most part. And then, on occasion, and Dr. Misra already mentioned, it's a chronic disease. So we shouldn't ever think that we do it one time and we fix the issue. What we're going to do is we're going to continue to treat this chronic disease with every opportunity we have in our armamentarium.
Great points. And when you think of these chronic diseases we treat, or these severe diseases we treat, we call them diseases and everybody recognizes it as such. Can you imagine not giving cancer chemotherapy to a cancer patient? Patients with chronic hypertension, not being able to give them high blood pressure medication, where would we be? We're in that state right now with regards to GLP-1s, where this is one of the biggest public health crises, and they're not getting access to these medications. They are expensive, we get it. So is obesity. So I look forward to further dialogue about making them less expensive and more accessible. But right now, there's actually a great alternative, and the GLP-1 pump that we're talking about, the gift that keeps on giving. So surgery is a great option from that standpoint. Linking this together, Dr. Misra, so many people think that GLP-1s and weight loss surgery, it's an either or. Either you take the medications or you have surgery. How can these two treatments be used together to help our patients?
Thank you for the question. I think that's actually a really good point to bring up, because I think we need to understand that obesity treatment is kind of like cancer care treatment. It really just depends on the individual patient of what they actually need to have the best success. So whether they need medications first and then surgery, some people need medications after the fact, sometimes it really depends on the patient. And I really do think that they can work very well together. I love being able to have the ability to have that tool there to be able to help the patient get where they need to go. We see a lot of patients, we always try and get them to lose some weight right before surgery. It does make surgery safer. So now, before a patient who's 200 pounds overweight and we say, we need you to go and lose some weight first, it was very challenging, which is why they were at this point. They have this disease. Whereas now we have medications where you can say, we're going to help you lose that little bit of weight just to make surgery a little bit safer for you, and then we can go to surgery to give you that lifelong therapy. And so being able to use them in combination is outstanding. I think it's really helpful, and it's going to make surgery safer. They're already very safe, but it even helps even more. So I think this is a really positive thing to be using it in combination together appropriately.
Great points. Dr. Sai.
Just wanted to follow up on that point, because you raise a really important point. Is it's not either or, and it's all of the above, and we need that all of the above approach, because as I mentioned, we're in this current and growing epidemic, and even with the availability of very effective treatments and very effective surgery, we're only treating about 1% of the patients would benefit from surgery with surgery. And even though a lot of individuals have been trying GLP-1 medications because of insurance barriers, cost barriers, side effects, a large proportion of those individuals are discontinuing them. So even accounting for those who are taking medications, there is still over 90% of the population who are suffering from obesity are not being effectively treated for that condition. So there is an ongoing need from a public health standpoint, and we've talked a lot about what this means for the individual. There's an important personal need for the all-of-the-above approach, but we definitely need an all-of-the-above approach for meeting the public health crisis and making sure for which communities the individual treatment options may be the most effective strategy. But like I said, it's not either or. It's making sure that we have access and utilization, get those people on those Peloton bikes, and not just having the Peloton bikes in their communities. So I think that's the challenge, and not just the professional societies and the physician community, but public health community. But this actually requires an all-the-above effort from society as well to make sure that we are using all of the tools we have available, treatments we have available, to solve this growing crisis of health.
Dr. Misra.
Sorry, this wasn't
No,
part
sorry.
of your this
You can
wasn't
see
part
the
of your
enthusiasm.
question.
I love it.
But so Dr. Sai made me think of something that I think is really important for the public to know, is that if you've tried the medication and either you stopped because of the cost, side effects, you stalled on your weight loss, it just wasn't working anymore, you lost 30 pounds, you have more that you want to lose. Surgery is a fantastic option. It's not that if the medications don't work, then surgery is also not going to work. It will. It's much more powerful than the medications. There's less side effects. Like we were saying, it's very, very safe. And so I just think it's really important for the public to know, because a lot of people are not actually getting it from medical providers. They're getting medications from online services, and they may not get that information. So I really think it's important for patients to understand that if the medications don't work, surgery is a fantastic option. You already know all the positive you're getting from the medications, you're going to get that with surgery. So.
Everything that you both have said is great, and Dr. Sai, I think you're alluding to it in the way you were saying it, which is we talk about that we only have 1% that actually utilize the option. I think the reality is that if we flip that around, and to Dr. Hutter's point, and I love the cancer analogy of this disease process, and that medications in some cancers can be treated with a medication alone. Some cancers can be treated with a surgery alone, and some cancers require both. And so here, could you only imagine if there was a cancer that 99% of the people were not getting treated for, but have a treatment for, how the world would be on fire? This would not be a discussion. It would be a very... The crisis that it is in the public health, there would be a response that would be very different. And so I think we must acknowledge that there are treatments, and we are leaving a lot of people behind. So.
Wow. Yeah.
We're passionate about this topic, so
We're passionate.
We'll keep passing the mic around, and we'll put you out of a job.
No, it's good.
Dr. Hutter. And I think one of the important things to realize, for people in the audience, kind of thinking, why are surgeons talking about treatment and lifestyle and public health and epidemics? I just want, one of the foundational textbooks in surgery, a book called The Metabolic Care of the Surgical Patient, when in the introduction to it, describes what medicine is, and that quote is, the fundamental act of medicine is the assumption of responsibility. And I think that is an ethos that we as a profession here as surgeons really embrace, that we are accepting the full responsibility of treatment and care of our patients who are suffering from obesity and metabolic disorders, and leveraging all of the innovation, insight, and training, of which surgery is the tip of the spear, but also provides, and this is the point I want to make, this multidisciplinary, comprehensive education for our patients. That is the hallmark of the approach for both ASMBS and the American College of Surgeons, and our accreditation and quality programs is not just about how we do improved surgical care. We're improving metabolic care for our patients, and offering comprehensive, multidisciplinary care with surgeons, obesity medicine specialists, gastroenterologists, dietitians, psychologists, to offer that complete treatment support for our patients. And as I mentioned, that's where the precision comes in, is tailoring the most effective options for patients. So I think that is an important element to, I think, how we all view our roles in taking care of our patients and going forward. And I think that is an important thing for patients to understand, is that when you come to see a surgeon, it's not just to get a surgery, it is to get a comprehensive education and informed decision-making about what is the best treatment option for them.
That's a great point. So if you're seeing a provider who's not talking about surgery, They're not providing about all the options you should be considering. So I think that's one of those things. Yes, we're glad that there are more than just surgeons out there. We all work as multidisciplinary groups. You come into this barber shop, you don't necessarily get a haircut. You get treated though, and it might not be a haircut, it might not be surgery, but we'll anything within that spectrum when you go and see a surgeon. When you see some of these other folks, they might not talk about surgery like they should be, and I think that's part of the conversation we want to have here. This has been a great discussion. We're looking forward to some other questions that are out there. Before just linking this together, we talked about stigma, we talked about access, and we talked about the multidisciplinary treatment and using the medications in conjunction. Failure is a term that we don't like to use. We can't fail our patients. We don't want to use the failure period. People come into us with the stigma that they have failed because diet and exercise didn't work, and everybody told them their whole life that it should work. And some diseases are stronger than others. They're just a higher grade, and we see that in cancer, like that discussion. Some people's cancer, you can do a lumpectomy and it's done. Some people, you need other people. We don't blame that patient when a patient's cancer spreads. We don't blame them, and we do everything we can to treat it. And here, we have, as a community, because there is a lot of bias and stigma, we've been blaming the patient. That's why they don't show up, because this stigma and this bias that's out there for them, and that's why when they come in, we want to treat them. And some people won't do as well as others with surgery or won't do as well as with medications. That's not necessarily their fault, right? It's a disease, and we need to treat that where they are. And we're gonna escalate it and give them medications on top of surgery or surgery on top of medications, and we're not gonna call them a failure because they're not. They're just being responsible people treating their disease. So hopefully there's some other discussions or questions out there. Anybody who's out there in the ether who wants to throw in some questions, we're happy to take some softballs, curveballs, or hardballs.
Thank you, Dr. Hutter. So the first question comes from Matthias Lowy. He is with Medscape en Español. And his question is, Dr. Ricardo Cohen, president of the International Federation for the Surgery of Obesity and Metabolic Disorders, has said, and I'll paraphrase, "We're not in vogue anymore, but we are cheaper." If you had to choose the main comparative advantage of bariatric surgery over GLP-1s, would you say cost effectiveness is at present the most compelling one?
Great question. Who wants? Well, the if so president throughout the question. I think in his presidential address he didn't say in vogue. He said it's not as sexy. But we'll leave that to the ASMBS president, Dr. Peterson, to answer that one.
Thank you, Dr. Hutter. You are correct. In his presidential address, he did use the term "we're not as sexy," and but the truth is, I understand what he's saying, and so the cost effectiveness is a compelling argument to this treatment of the disease of obesity, and in fact, all of the comorbidities that go along with it. But I think what we really need to remember, and Dr. Misra already highlighted it, was quality of life. And Dr. Sai mentioned years of life. I mean, these are things that we're providing with the treatment as well. And so wouldn't you want the most cost-effective treatment to give you the most bang for your buck, if you will, to give you the most life back, to take away these other disease states that are keeping you from doing other things? So the reality is, I think you can't just leave it at cost. Cost is huge, and costs to the health system are huge. So we want to be good stewards of healthcare that we're providing. And so if you asked me, which thing would you do to save the most money and help the most people? Well, we know today that that's surgery.
Dr. Sai.
To follow up on that, I think the way to think about it is not what treatment is the most sexy or vogue or cost effective, is what represents the greatest value, both to the patient and to the healthcare system and for public health and for society. And I think that's the way to think about it. It is incontrovertible that right now that metabolic bariatric surgery is the highest value for the patient, both in cost-effective terms, given the high cost of the GLP-1 medications. They are clinically effective, but very expensive, and undergoing the permanent, the medications can stop, but the surgery, you can't take that away. The idea of that is that it's long-lasting is the way to think about it, is that the effects are long-lasting and durable. So in both a cost-effective terms, I think it's value. In what patients matter, living sort of functional, high quality of lives, living longer, it's high value. And I think that's the way to think about it, is it's high value also because it's a comprehensive, part of the comprehensive treatment approach too. So the way that I would frame this is that, thinking not just about what's popular or not popular, what's expensive and not expensive, but how do we kind of put it in the patient's perspective of what is most valuable for you to meet your personal goals for your health.
Dr. Misra.
I think just to add to that, I think a key thing that you brought up, Dr. Sai, is that sustainable and durable, right? We want something that's going to be long lasting. And I think also maybe patients need to understand we're not just talking about diabetes and high blood pressure. I know we've brought up a lot of times. Maybe patients don't understand, would I be a candidate for this, right? So the new guidelines came out by ASMBS and IFSO in 2022 of a BMI of 35 with no medical problems, or 30 with one medical problem related to obesity. But that's not just high blood pressure, diabetes, sleep apnea. It includes those, but it's also someone who has osteoarthritis of their knees or degenerative disc disease in their back. These are things that the very common, you probably know 5 people in your lives who have these diseases that are just normal diseases, but it's like they're carrying a fully packed suitcase on their back everywhere they go. And those people would be great candidates for surgery to long-term help them, even if they need a joint replacement. Those replacements last longer when we're able to do something about that weight. So the cost effectiveness is not just the years, that's fantastic, the years of life, the decreasing cancer risk, but it's just the day-to-day people who are like, I just need to lose 50, 60 pounds, or we can help them. I mean, I think that it's really important for them to see that you are candidates, not just the 600-pound patients that are looking at surgery. This is so safe. You're going home the same day or the next day. My patients describe it like doing 300 sit-ups. I've never done 300 sit-ups. That sounds very sore. But minimal pain medication, usually on extra strength Tylenol by day 3. I mean, it's really quick recovery. Patients are back to work in a week. I mean, it's amazing what we're able to do to help them long term. So
I think we're fortunate to practice in a field where we get to do preventative surgery. Right? It's not that it's prevention or treatment or prevention or surgery. As you mentioned, even if you're a quote unquote relatively healthy patient with class 3 obesity and you don't yet have a lot of the other medical conditions like high blood pressure, high cholesterol. A lot of my patients come in and say, my grandparents or my parents have diabetes and high cholesterol. I see what their life is like, and I don't want to end up like that. Mm-hmm. So we are remarkable, and it's remarkable for patients to have the option of a very effective treatment. And I think we're thinking about sort of whether there's an incision or not an incision, if there's a cut or not a cut, but really the way for patients to think about in terms of what's popular, not popular, what's cost effective, what's not, what's high value or not value, is not the mechanics of what that treatment looks like, but what is the sort of most value for them. And in this case, again, it seems counterintuitive that a surgical procedure can actually be prevention. So I think it's a remarkable moment in public health and clinical medicine where the lines are blurring between what is considered historically treatment versus prevention. I think that's the exciting era that we're in.
Yeah, great points. The clock is ticking. For a patient who comes in with pre-diabetes or just being diagnosed with diabetes, we can make that diabetes go in remission a high percentage of the time. Once they've had it for 10 or 20 years, they're on multiple medications, and then it's harder. So there is a timeliness to what we do, and we like to fix people. That's why we're here. Hopefully you got that theme. We're fixers in the problem. So if you get to us sooner, we can fix it as better, and so we'd love to do that as well. Other questions from the audience or online?
Yes. So the next question comes from Fran Kritz. She's a freelance healthcare writer, and her question is: should doctors be weighing surgery versus injections versus standard diet and exercise at each patient encounter instead of just defaulting to the drugs?
I mean, I'd love to say that I think Dr. Sai actually addressed that really well, because he's, with the use of this precision, treatment, that's exactly what we should be doing, is talking to patients and customizing the treatment for their disease process, right? We don't just throw one thing at everyone. And that is, unfortunately, I would say, somewhat in the public currently, with access to a medication, someone can just go online and get it without having a true conversation about the disease and the treatment that goes along with that disease. And the medications may be fantastic and a good part of that treatment regimen. But the disease that we're talking about isn't just diet and exercise treatment only. That's a piece of the whole puzzle. But the reality is surgery, medication, endotherapy, right? Endoscopic therapies. There's a huge range of things that we can offer. And so to answer that question, I believe it's customization is for the patient. And as Dr. Hutter mentioned, it is that full informed consent that the patient is aware of all of the options to treat their disease.
Dr. Misra's head's going to pop off if she...
I totally agree with Dr. Peterson, obviously, yes. But I think that is a great question, because yes, I do. The answer is yes. I think that anytime a patient comes forward and asks for, what do you think is the best option for me? I think having an understanding of expected outcomes is so important, because we have the numbers. So if they're expecting to lose 80 to 100 pounds with the medications, that is more than likely not going to happen, right? And so they need to do the math, they need to look at the numbers, and they need to understand what is the best option, so they're not wasting a lot of money, a lot of time. If they waste 6 months and they lose 14 pounds, they're going to be very frustrated, and they'll say, well, this just doesn't work, like everything else didn't work. But there is options out there that are safe and effective. And so I think just having that information, the education, and if providers don't know the numbers, then they should send them to somebody who does, and they can explain it all to them. And just because you go to a consultation with a surgeon does not mean you have to have surgery. And I tell that to patients all the time, is that I just want to give you the information, and then you decide what you want to do. And then and together we find the best option for you. And even if I believe that they should be having surgery, but they say, no, you know what, I really want to try the medication, I'm not ready for surgery, we do that. And that is appropriate, because we need to figure out what is the best path, because they have to commit to the lifestyle changes that they need to make, and we want it to be safe and effective for them. But then if some time goes by and they say, you know what, maybe I want to have surgery now, which is fantastic, right? We came to that decision together, right? And now they have a lifelong of healthy, better quality living. So I just think that, yes, we should be offering all the options.
Any other questions that you have?
Yes, the next one comes from Kevin Horty with General Surgery News. And his question is, how do we get accurate information about the benefits of bariatric surgery directly to the public or patients and the primary gatekeepers who see those patients, so that the 1% becomes 10%, 20%, et cetera?
You're looking at me. Okay. Well, thank you, Kevin. I appreciate that question. And so how do we get that information out? How do we provide the accurate information? And that's a tough question, because we have it, but it's the mode to get it out, to let people know that this is effective. And so we do have options for that. There's social media campaigns. Certainly, there's a lot of advertisements, commercials that are out there, again, raising the awareness, but making sure that information goes forward to the public, I think, is critical. A big part of that is just education and understanding, removing that stigma, letting people know that this is the thing. In fact, our frontline folks, the family practitioners, our PAs, our nurse practitioners, our ER physicians, individuals who see these patients suffering from this disease, giving them the tools, the opportunity to know that I realize this is an option for them, and I should send them for that kind of care. I believe that that's how this needle moves. So And I'd welcome any other comments from the team.
I think that's why I gotta say we're grateful to have you all here, because you guys are the ones that are gonna be able to get that information out there, because it's not just patients coming to their physicians to get information. These are people, everyday people out there, and not knowing that maybe I should be seeing a physician about this. So I hope and pray that you guys will be able to help us with that, to get that information out, accurate information out, to be able to help people decide what is gonna be the best care for them.
And I agree completely. It requires partnership, and the partnership in education is not just about the numbers, because again, I come from public health and I can cite population averages all day long. But what matters for people is what this actually means for them, and that's binary. Either it happened or it didn't happen. And what we need is to build the partnerships, build the trust, and patients are doing that. But we need to continue to do that, embrace that, and also tell stories. Again, that's what I think fuels all of us, right? We're not sitting there saying, this month I reduced diabetes, on average across, X%. I'm saying this patient, 6 months after her surgery, got a job promotion because she actually was, really seen for the first time, and she's off of her insulin medication, and then she is able to keep up with her daughter at soccer practice. So, these are the stories that matter for patients, and that the public need to understand. Other physicians need to understand how life-changing the procedures and treatments can be. And we talked a lot about the quality of life, and we can cite the numbers but what really matters is the quality of life that a lot of patients are experiencing, and I think that is a really, really powerful story to share.
The surgeons here feel like this has been an echo chamber. We have seen the patients. It's amazing how their lives change, and we say it to ourselves, and it doesn't go outside the room. So we're excited that it's going outside the room. This education aspect, this awareness, that's probably the best things about the GLP-1s. It's now a conversation. And when you look at this conversation about treating a disease, and that it is a disease, you have all these patients who are living what it's like to have a taste of not having that disease for a while. It really brings up awareness, which is what we're very excited about. So again, very glad you're all here and listening. One of the best things about GLP-1s is it's bringing this to the attention, and we have to think about all treatment options for this disease. I think we have time for one more question, so let's do that.
Yes, this one comes from Dr. Peter Kim, who is also with General Surgery News, and his question is, what is the role for multidisciplinary evaluations for combined medical, surgical, and prehabilitation regimens tailored for morbidly obese patients in regional centers of excellence?
Great question.
Well, thank you for looking at me.
You're to the right.
Okay. Dr. Kim, thank you for the question, and I would say the pie in the sky for treatment of this disease is to have a comprehensive center where someone can walk in and have access to every piece of the treatment modality that we provide. And so there are some centers that are doing that. So the centers of excellence, as we used to call them, but are now the Metabolic and Bariatric Surgery Accredited Quality Improvement Program, MBSA QIP centers. They're accredited centers, and almost 1,000 of them in the United States, all provide that level of comprehensive care. And some have the medication component as well. But there are certainly systems that provide all of that within their practice. As Dr. Misra already alluded to and mentioned, surgeons also can prescribe. So you're coming to the group that actually can offer it all. And so being aware, finding the surgeons, and I know Dr. Hutter was going to let us, how you find the doctor and how you find the program, will be able to provide that. So that's where it's at. It's there. And if you have anything else to add to
I think
that.
you summed it up very nicely. I think, the idea here is that there are a lot of treatment options. Surgery is definitely one of those treatment options. If you're not being told about it, then look for that information. there are a lot of places to look online. Don't trust everything online. There's some good resources from the American College of Surgeons that we'll bring up here. Not only to find a hospital, to look for high-quality hospital. We talked about these accredited centers, and it's not just a ones or twosies. It's almost 1,000 centers. So look through the ACS for accredited centers in bariatric surgery. The ASMBS provides information like that. And at facs.org/obesity resources, we'll provide some of that information as well. So we want to all of our patients to be well informed, to think about all the best options, and understand that there is a lot out there, and that we're excited. We're excited for obesity going. We're excited actually to be out of a job as a surgeon. No, it sounds funny, doesn't it? But we're here because we're doctors, and we chose this because we can make an impact. And with surgery, it's a great impact. If the medicines were better, hallelujah. They're not. Right now, and so surgery definitely has and probably always will have a role. But I really thank everybody for being here today. I thank for the opportunity to raise this awareness, to talk about this disease and how we're treating it. So thank you all.